Good evening. Well, it is very well known that children under 5 and so many others tend to suffer recurrent cough. That is about 6 to 12 episodes a year. That is almost a child getting a cough episode every month. But however, there are those children whose cough seems never to clear, or that seems to happen almost every 2 weeks or every other week. What could be the problem? Is it something more than just a simple cough episode? A third of these children have been seen to get a wheezing episode. And the question is, do all those that are wheezing, is it just an innocent cough? Is it just a viral infection or something more than that? Now, there is something called asthma. Asthma has been seen as the #1 leading cause of chronic, that is non-communicable diseases, and the #1 chronic illnesses that has been seen in children. And it is one of the reasons as to why some of the children's coughs may not clear as anticipated. So this week on Pediatric Voice, we are going to discuss asthma in children, and I am your host, Dr. Helen. We are going to look at it in detail. What exactly is asthma? How can we not notice a child that is suffering asthma, and what can we do to make sure that we make our child live a happy life? And today in our studio we have Dr. Liz Kutamba, who is a pediatrician, but first let's look at her profile.
Dr. Elizabeth Kutamba, a consultant pediatrician, medical director and proprietor Health Haven Clinic, a member of Uganda Paediatric Association, a deputy director for East African Center for Vaccination and Immunization, a member of the Tobacco Control Advocacy Committee, a member of the STAMP, Strengthening Asthma Management, a child health advocate, passionate about school health issues.
Welcome to the show, Dr. Elizabeth.
Thank you very much, Helen, and thank you for having me. It's always a pleasure to come to this show.
Thank you for allowing to teach the world. And this time around, we are not talking about vaccines. I know you're very passionate about immunization and prevention of illness in children, but I think also managing asthma very well goes into the preventative part and improving the quality of life of children.
That's right. I know for me, anything talk about children and advocating for them, I'm always happy to do that.
Thank you. Yes, so today, as we earlier introduced, we are going to discuss asthma in children. We are going to look at the different aspects of asthma. That is, what is asthma? How best can we identify a child that is living with asthma? How can we manage a child that is living asthma? What can you do in your means as a parent to make sure that your child lives the best of their life like any other child, to make sure that their livelihood is not interrupted? Remember, it is one of the causes of developmental delay and poor weight gain in children. But before we indulge into the discussion, let's look at some statistics about asthma.
Asthma is a chronic lung disease, often of genetic predisposition associated with narrowing and swelling of the breathing pipes. It is characterized by recurrent or seasonal coughs, whistling breath or wheezing, chest tightness, chest pain, and difficulty in breathing. Asthma is the commonest non-communicable disease affecting both children and adults, with about 262 million people affected and 455,000 annual deaths. Asthma affects about 1.9% of children of under 5 population, with about 38.7% of children living with asthma suffering at least one attack annually. Uncontrolled asthma is associated with sleep disturbance, interrupted daily activities like sports, school absenteeism, poor weight gain, and poor development. Efforts to improving diagnosis, treatment, monitoring, and control of asthma has immensely seen to be a success in improving the quality of life of children living with asthma, as well as reduce childhood mortality and morbidity.
Elizabeth, you've had the documentary on asthma. What is your comment?
First of all, it's amazing, you know, to see those images, and it helps to demystify the fears that people have when it comes to use of it, these inhalers. So I'm happy that you shared some of these images. How I wish that even we had black children, Ugandan children, using these inhalers, and maybe people could, relate. But having said that, asthma is a big issue. It's a serious problem when it comes to the burden of disease. And when I say burden of disease, I'm looking at quality of life, affecting quality of life. I'm looking at school dropouts, the quality of time wasted when these children are in and out of hospital, for outpatient visits. I'm looking at parents or caretakers leaving work, always visiting clinics, to manage this. So it's such a global burden. And maybe just for our viewers, what is asthma? Asthma is, when you say asthma, people, first of all, it's such a technical word that people don't understand it, So they think it's a weird disease. And that even explains why most people don't want to even...
Actually, most parents out there do not want to ever hear the diagnosis, asthma. And very often I've seen health workers are terming it all sorts of
names.
Of fancy, hyperactive airway disease,
so that's,
allergic cough, and so many other things. Actually, first I would request you to define asthma, and then from that maybe we can go into those so many fancy names.
Asthma is basically, it's a Greek word. It comes from a Greek word called azein, which means to like breathe heavily, to use effort to breathe, that kind of thing. So it comes from that, and basically it's about hypersensitive airway. You have a gene, the way you're made up, it makes you susceptible or very sensitive to certain environments. And because of that, you have this predisposition to overreacting to a given stimulus or something within the environment that will make you behave differently from the rest. So that's a genetic predisposition I'm talking about. So you undergo what we call chronic inflammation. So
wait a minute.
Yes.
So you have a gene. In other words, in your makeup, in your blueprint, there is something related to asthma.
Yes.
Okay. Then on top of you having a blueprint of asthma,
to make you overreact,
you get something that makes you overreact.
Yes.
Okay. So you have that blueprint of asthma, of allergy.
Yes. Which asthma is actually chest allergy. It is respiratory allergy.
Okay. So you have the blueprint of allergy in you, and then you have something that stimulates the reaction
within the environment.
Yes. So there is a role of the environment.
Exactly.
And then,
and you, the person who has that gene, it may be dormant until you get exposed to that particular thing within your environment that will make you overly react compared to the rest. To
the rest of the population.
Yes.
Well, thank you very much. Now that you've said that it may be silent, I have a relative, actually, who got her first wheezing episode almost 16 years of age, and everyone was like, we've not had allergies in this family.
I know.
So you mean some people can be living with this allergy and it is silent until they get a spark of.
Exactly. So you have a dormant, it's dormant until you get, I don't want to call it a right environment for it, because it's usually a bad environment.
The appropriate trigger, let's say appropriate trigger.
Yes. So then you can show symptoms. And we can't explain why you can grow up to a certain age without showing symptoms, yet you have been in the same environment, So it depends on your immunity and so many other factors. But for asthma, or allow me to say respiratory allergy, will only happen if you are exposed to that particular stimulus within the environment and to make you overreact.
So respiratory allergy, it means the allergy is within the chest, within the breathing pipe.
Yes, that's
so in other words, allergies can occur even outside, in other parts.
Areas. So you can have allergy to the skin, allergy to the eyes, just getting in a dusty environment, someone starts rubbing their eyes. And you have, when I say respiratory allergy, I mean from the nose up to the lowest part of the respiratory system, up to the lowest, smallest airways. So even you can have nasal allergy. So exactly the way you sneeze a lot when it's dusty, when it's raining, when it's cold, or when there are fumes or smokes, it's how it also happens within the lower airway, and then you start producing all those symptoms. So basically that is chest allergy. I will usually tell my patients that asthma is chest allergy. And of course they prefer to hear chest allergy than the asthma. And I wouldn't be surprised because it's a weird term, right? It's from a Greek word. It is foreign, so it's not normal. So when you say asthma, people think it's weird, but it's actually chest allergy.
Okay. Now you've said asthma is chest allergy.
Yes.
Do all people with asthma have allergies?
That's a very good question. People with asthma, they have chest allergy, but they may also have other allergies. So, for example, you may have skin allergy, you may have food allergy. So there is a tendency for people with asthma to have other associated allergies. But not that every person with asthma has different allergies.
Oh, so what are the examples of the different allergies they may have?
So I've talked about eczema, like, you know.
That is the skin?
The skin allergy.
Skin rashes.
Yes, you know, you find this rash that doesn't go. It's episodic, it comes. Maybe if you apply a different soap, change a cream, it's always coming, you know. Different clothing, you find the skin is quite itchy, and it's over time. And also you can have allergic eyes, allergy in the eyes. As I mentioned before, you can have what we call allergic rhinitis. You get flu.
Recurrent runny nose.
Yeah, runny nose out of nowhere. You're okay, the child is running and suddenly starts, you know, sneezing and getting a runny nose. So you can have that. Also even food allergies, actually. There are also other associated allergies.
Okay, thank you very much, Liz. Now, there are those fancy terms.
Yes.
People tend to use, and parents actually love them so much as compared to the word asthma. There is one, it's called allergic cough, and then there is hyperactive airway disease. Do they actually mean asthma, or they are something else?
You know, when you look at asthma, as I said, it's a complex term, but hyperreactive airway disease, allergic cough, they're actually describing asthma. They are part of the asthma, you know. So you're saying allergic cough, this child has recurrent coughs. So I think it's an allergic cough. You're actually saying this child has asthma, and cough is a symptom of asthma.
So it's actually a soft way of saying this child has asthma.
That's right.
Okay.
Yes.
Is it right to soothe the parent's mind other than telling them the child has asthma?
You know, it's not right at all. You know, it's important to tell the parents the right information, give them the right facts, but try to communicate simply so that they understand, and also be patient. Because you see, there are a lot of issues, there are a lot of misbeliefs that people have in their minds. So to get this person to understand and change their mindset, it takes a bit of time. So sometimes we go, you know, process by process. So, but we must offer the right information. I'll tell you the child has asthma. I think it's asthma because of A, B, C, D. So I want to give this medication, and we check, we follow up and see how we move together. So you follow them up. By the time they actually realize that, oh, actually these inhalers have worked, this child has responded to this treatment, then they feel now they can trust you, they can believe you, you know. But the first day, it's usually difficult, and most people don't want to hear those weird diseases. But it's important to say the right information.
Thank you very much, Liz. As you've very well seen with the statistics, asthma is the commonest chronic non-communicable disease actually in both children and adults.
That's right.
It is even worse among children. It is the number one chronic disease amongst children, and yet it is one of those diseases that has faced the biggest rejection.
That's right.
In terms of diagnosis. Parents out there do not want to hear the word asthma.
That's right.
So maybe before we delve so much into the discussion, what exactly happens with this thing called asthma? How does it happen?
As I mentioned, Helen, that asthma is a chronic inflammatory disease. It means that, yes, you have the gene.
I don't know.
Oh yeah, that's right.
Yes,
some
you can make use of that.
Yes. So as I mentioned, is that you have the gene that makes you susceptible to overreacting to something within the environment. So usually we have this, I'll demonstrate this as our normal airway, you know.
Breathing pipe.
The breathing pipe. So it's wide open. You can see
it is
it's clear, it's blue,
purplish.
purplish in color. You know, you're breathing without efforts. So if you're breathing,
air freely enters and goes out.
So when you're breathing, I shouldn't hear you breathing.
True.
Yeah. It's
and
effortless.
you should not even notice.
I shouldn't notice. Otherwise, if I hear you breathing, I can notice you're breathing, then there's a problem. So the normal air looks like this. But in asthma, or what we would say respiratory allergy, you have changes happening. So as this person is exposed to this environment that has the stimulus or the allergen, if I use that word, something that will make them react, overreact, for example, dust, for example, cold air, like seasonal changes, like it's raining now, smoke, like, you know, tobacco smoke, fumes from cars, candles in the house, dust mites, it could be inside or even outside, like pollen, anything that will cause you to overreact. So it will cause changes in your airway, from the bluish now to reddish.
It becomes swollen
and red. You know, like, and that's what we call inflammation. You get now cells coming in, the body cells coming from other places and coming in here. So you find that an airway that was initially wide open, it starts narrowing because the muscles have swollen. Remember, the muscles for breathing, which are supposed to open up, you breathe in and then out. You relax as you breathe out. So they start narrowing. So the space for your airflow reduces.
So you begin struggling a bit.
Exactly. And this is what we call inflammation. So this process that makes your airway narrow and swollen, it is chronic. It is ongoing all the time. So you might find this child is in this environment. They may cough a little today, but the process is subtle. It is taking place, ongoing, every day, every week, every month, every year. So they struggle, breathe in, out, with difficulty. Over time, if nothing happens, then you come to this. So you have a lot of mucus piling up, and the airway has actually
almost closed.
Remember, we are coming from here. So if you can see, there's a huge difference.
So the breathing pipe is almost not there.
It's actually almost not there. So in asthma, we have chronic inflammation, we have narrowing of the airway, and restricted airflow. So all those three are happening. So if we do not do anything to reverse this inflammation,
it can actually completely close off.
Exactly. And over time, this airway, as this child grows even into adulthood, now it becomes restricted airflow. It becomes hard. Like air cannot, even if you do what, it cannot move. So you find that some children or some adults end up getting what we call chronic obstructive pulmonary disease. It's a disorder. It's a disease that you can't do much. So maybe
you can't do anything to open up the breathing pipe.
Exactly. It has fibrosed, it has become thick, it has scarred. There's a lot of scars, and it is quite tight. You can't do much. So it is important to address these issues, because you can do a lot to reverse this so that you restore the airway back to normal, and you improve the quality of life for this child. So basically, asthma is a chronic inflammatory airway disease.
Thank you very, very much, Dr. Elizabeth, for that wonderful explanation. You are watching the Pediatric Voice, and we are discussing asthma in children, one of the commonest chronic illnesses among children, and it is one of the reasons as to why your child may fail to grow very well, to gain weight, to develop very well. It is one of the reasons as to why our children get to miss their school days, and as well as parents missing work because of a sick child. Please feel free to tune in to Bethany TV Uganda, that is on Facebook and YouTube and X Spaces, as well as www.bethanytv.org on on our website to check it out, as well as checking it out on 841, that is on GoTV, and 170 on free to air. So Dr. Elizabeth, what are the risk factors? Why would one child get to wheeze and another one doesn't get asthma?
Yeah, one, I've talked about the genetic predisposition. So you find that in the family there's a gene, especially for those first-degree relatives, you know, mother, father, first cousin, siblings, you know. So there's always a genetic predisposition. We have also seen other aspects like obesity, you know, all those dysregulate the immune system, so it makes it imbalanced, and maybe it can also, at the end of the day, predispose this person to asthma. Also, environmental risk factors, which are now on the increase. Air pollution from these fumes.
There's so many factories
tobacco
we are coming
smoking.
up.
Yeah, there's factories.
The DMCs we are driving.
You know, a lot of smoke, tobacco smoking, a lot of fumes in the environment. All those, they are a trigger. Actually, I was reading about an article some time back, and they stipulated that maybe in the next so many years, a good proportion of the population will be asthmatics, you know, because of the air pollution.
Remember, you said we are living with our genes.
Yes.
But we just don't have the right trigger.
Exactly.
To spark us up. So, that means as the population grows, as we go ahead in this world, we are going to get more triggers.
More triggers.
So some of us who are living with our silent allergies will come up.
I know. And also, by the way, think about it. If you're chronically, constantly being stimulated with this, even without the gene, constantly inhaling these fumes,
the dust, the fumes from the cars, from the factories.
I talked about chronic inflammation. Even without the genes, the chronic inflammation will trigger an asthmatic disorder, because it's about a daily chronic
inflammation. We are daily exposed.
Yes.
Does that mean, is that the reason as why, you know, we have people who have worked in factories, timber and so many, they eventually tend to get lung-related issues.
Yeah, just because they're inhaling particles, they're inhaling fumes, they're inhaling things that are causing inflammation on their airway. So automatically that will cause, you know, fibrosis, will cause changes in the airway, narrowing and thickening, and that can actually cause air obstruction and eventually asthma.
Okay, thank you very, very much. Dear viewers, you are watching the Pediatric Voice and on Bethany TV for Health, and we are discussing asthma in children with a wonderful Dr. Elizabeth Kutamba. Let's come back after the break.
Bethany TV for Health.
Health Minutes on Bethany TV.
Germs can spread from person to person or from surfaces to people. Washing hands can keep you healthy and prevent the spread of germs, as well as protect vulnerable populations who are more susceptible to infections, such as young children and the elderly.
The purpose of hand washing is to clean hands, to remove dirt, minimize on microorganisms, and also to prevent crossover of infections from one person to another.
When can you wash your hands?
Washing hands depends on your setting. If you're in a hospital setting, you should always wash your hands before and after touching the patient. Preparing equipments to work on the patient, you should wash hands before. In a home setting, you should wash hands before eating.
To properly wash your hands, wet them with clean running water. Apply soap and lather for at least 20 seconds, making sure to scrub all surfaces of your hands, including between your fingers and under your nails. Rinse your hands thoroughly with running water and dry them with a clean towel or air dryer. If you are unable to wash your hands with soap and water, use an alcohol-based hand sanitizer that contains at least 60% alcohol.
Better healthcare for a better tomorrow. That was the Health Minute.
Introducing Medical Minds with Dr. Andabati.
And these tubes can be so delicate that sometimes they get damaged. Some people have gotten the damage because they have undergone some operations. So damage to the tube system is one of the big problems we also do see.
The groundbreaking show that takes you behind the scenes of the medical minds.
You will explore cutting-edge treatment and technologies revolutionizing reproduction health.
Now, in retrograde ejaculation, we get damage to the junctional valves, which I could should say.
Learn about the science behind fertility, contraception, and emotional journeys that several women trek.
Every Sunday, 8 p.m., live on Bethany TV. Bethany TV, for health.
Welcome back from the break, and thank you for watching Bethany TV for Health. You are watching the Pediatric Voice, and I'm your host, Dr. Helen Namsoke. And today we are discussing asthma in children. We have hosted Dr. Elizabeth Kutamba, who is a pediatrician and the CEO of Health Haven at Bokoto there, and she has had a wonderful discussion with us about asthma in children. We've clearly defined asthma, what really brings asthma, the risk factors to asthma, and so much more. Please feel free to watch Bethany TV. That is on Bethany TV Uganda. That is on Facebook and YouTube and Expresses. Please feel free to follow, share, subscribe, and call in your friends to watch so many interesting topics, and especially the Pediatric Voice, where we discuss several topics on child health and making sure that you have a healthy child. We basically discuss, wow, how best can you do it at home to make sure that your little one is healthy. Remember, if your child is healthy, you can be productive in the boardroom as well. So, Dr. Elizabeth, as a parent out there, you know, so many times we see our children coughing and so much happening, they're not growing well, and we actually don't know what is the problem. As a parent out there, how would I know that my child could be having asthma?
That's a very important question, Dr. Helen. You know, as I mentioned, it's not unusual for a child, as you rightly said. At least an average child might have about 8 to 10 episodes of cough
in a year. Almost once every month.
Yeah, and that's normal. Yeah, but again, you want to see if this child's cough is variable. Is it, and also it varies in terms of time and also intensity. So what do I mean? If, yes, this child gets a flu and cough, you'd expect that within
a week should clear.
Yeah, okay, and you go back. Maybe after a month or so, you pick another bag. But if this cough is quite persistent and it varies with time, you find that when it's cold in the morning or late in the night, child coughs. When it brightens out and it's warm,
the cough disappears.
Yeah, or if the child runs with activity or exercise, they go swimming, child is coughing, and they tend to cough and cough and cough. And maybe it's usually a dry cough, and may be productive, but most times a dry cough. Child is laughing, they're happy, emotions. They're happy, and out of that, child is coughing, is wheezing. Or child is anxious, or they're stressed, and they're wheezing, they have difficulty in breathing, they're coughing. That is asthma. So basically this cough that is persistent, that is more than 2 weeks, you're coughing, especially in the night, in the evenings, that is an allergic cough. That is asthma.
Okay.
So such a child would need to be evaluated so that we look at other factors. And most times you might find that if you ask the parents, they said, oh, actually, I think I also have the same symptoms, you know. I usually sneeze when it's cold, or I cough once in a while, you know. So that is a history that is strong in the family, that there is already a history of allergy in the family. So we look at the cough, the nature of the cough, the duration of the cough that is quite stubborn, and if there's a family history of asthma, for us to gauge that indeed this is likely to be asthma until proved otherwise. And also the other extreme emotions I've talked about and other associated environments when this child otherwise coughs, you know. Also we look at if you know, sometimes these parents would say, no, it's the usual. They are used. That's how,
he usually coughs in the night.
Yeah, they'll say, even when he gets a cough, it's always like that. It's the usual. We are used to that cough. No, you cannot be used to the cough because it's not normal. Otherwise, a normal child wouldn't be coughing every time. Okay?
True.
Yeah. So, and sometimes they also get difficult in breathing, chest tightness and chest pain, and wheezing. Now, wheezing, you know, there are those sounds that the child will make when they are breathing.
True.
They may
like
be
we said,
audible.
Breathing should be silent.
Exactly. But you might find a child is making a sound when they are breathing. And it can be even audible when they are sleeping. They usually say like a pussycat, but most times, you know, you never hear pussycats breathing, you know. So you may not tell. But at least you may hear an abnormal sound, like a singing sound coming from his chest or her chest. So, but not that every child with asthma has to wheeze. So we have non-wheezers. They are coughing, but they are not wheezing. And that's where we go wrong as health professionals, because we think asthma, if I listen, there must be a wheeze, which is not true. Okay.
Sometimes the chest is just silent.
It's silent, and that's very bad. And
it's actually life-threatening.
So we look at other conditions, other factors. But most times it's difficult in breathing, following what I've mentioned, whether they're playing and then the child starts breathing badly, or coughing that is quite a little stubborn, more than usual, what we've described, wheezing, and also a history of asthma in the family. And we base on those symptoms, again, to look at whether it is mild and intermittent, meaning it's once in a while, once in 3 months, once in 6 months, or it is actually persistent.
That is, it is always
there. This cough is always there. So we look at how many episodes for us to classify whether it is mild asthma, moderate asthma, or severe asthma.
Yeah. Yes, doctor, before you go ahead to classify, you kept on saying there is a gene and there is a trigger.
Yes, that's right.
Our viewers out there would want to learn what are those triggers of asthma.
One's about, we've talked about the environment. So it could be the internal environment where the child lives within a home, or the external environment. Most times for the external environment, let's say the weather, we don't have much control about it.
It's
cannot
cold.
Say it's not
like
going
now
to rain.
It is a rainy season.
Know? Yeah, so those are some of those external environments. But within the home, where most times we try, because the gene, you can't do much, that's your blueprint. But the environment within which you can control, you try. For example, a child may be reacting to dust mite. Try as much as possible to clean up. Cockroaches. Try as much as possible to fumigate and clean up, but also don't fumigate and put the child there, because also fumes and these other irritants, you don't know how the child will react. Dust, woolen, you know, furred animals, like people who have pets. There are those other, fur that may be also another trigger for asthma. We usually talked about carpets, these wool carpets.
The woolen carpets.
The woolen carpets, woolen blankets, anything woolen in the house. So some of those pollen from flowers, the children who love flowers, and every time they inhale, they get an asthmatic attack. Yes, the natural flowers. So basically those home
fumes,
perfumes, candles, you love candles, you want to put candles in the bathroom, everywhere, and then these fumes and the scents can actually be triggers for this asthmatic attack. And respiratory illnesses, like a normal viral respiratory infection, where a normal cough and flu may actually trigger an asthmatic attack as well.
They kept on saying smoke as a trigger. So is it from the charcoal, from the firewood, gas?
Anything. Actually, even from gas. Because, we always think, of course, the kind of fumes from cooking that you get from gas is not as bad because gas is clean. It's clean. It's clean. You don't have a lot of fumes from there.
True.
Other than that, so it's a little safer compared to charcoal from this stove. The kerosene stove.
From the kerosene
yes.
stove, from the firewood.
Firewood, all those fumes are also very bad. Or even strong, I know some children, when they're cooking in the kitchen and they're cutting onions, frying, the child can start coughing and they get into an asthmatic attack. So those strong scents as well, and spices can also be another trigger.
Thank you, Dr. Elizabeth. Now, as a parent, you've said it looks like asthma is an emergency. So as a parent out there, what can I do in case, first of all, how would I know that my child has had an attack?
Yes.
And then two, and what can I do about it? Okay,
that's very important. Not every child who is having difficulty in breathing is an asthmatic child. Not everyone who has a wheeze has asthma. So it is important to look at those basic things I've talked about. But should your child get difficulty in breathing, it is very important to run to the health facility, because we need to establish whether this is pneumonia, whether this is asthma. Because, and especially if it's the first time they're making this diagnosis, if it's the first time. If it's the second time or third time and your child has asthma and
they always suffer these.
At least a health worker should have told you what to do, given that you have initiated on treatment. But the first episode, it's always important to rush to hospital. They find out why this child is having difficulty in breathing, and why they have chest pain, or why they can't breathe well, so that we ascertain the cause of this. Because it could also be a viral wheeze. We've seen, especially young infants, when they get what we call bronchiolitis. These are viral, other viruses that may affect or inflame the airway. Can also give you symptoms that
similar
are like
to asthma.
Exactly. Or a child who has inhaled a foreign body. Children swallow things, coins, beads. So they can inhale and something goes into the trachea, in the air, in the windpipe, and then they get difficult to breathe. So foreign bodies, viral infections, they can also mimic or present like asthma. So
in other words, it is not a parental diagnosis.
No.
If the parent's role is to suspect whether their child has asthma or not.
Exactly.
And then take the child to the facility, let the professional make the diagnosis for them.
And thereafter, it becomes a partnership between the parent, the child, and the health professional, because they work together to walk the journey
of this asthma management.
Yes.
Thank you very, very much, dear viewers. You are watching Bethany TV for Health, and we are on the Paediatric Voice, where we are discussing asthma in children this Wednesday. We are really very sorry for that technical hitch-up that has just happened a few minutes back, but please let's keep focused on the discussion about asthma. Now, Dr. Elizabeth, can asthma be diagnosed? Are there tests that can be done to confirm whether the child has asthma? Because very often as health workers, we face children coming into the facility and the parent is like, I'm tired of this cough, I want you to do tests. Or sometimes you tell a parent that this child could have asthma and she's like, confirm it. Are there tests that can be done to diagnose asthma in children?
That is a very valid question. When you say asthma and it's a weird
and the parent is like, how sure are you? You can't just look at my child and say my child has asthma.
I know.
Confirm it.
I know. And the good thing is, most of the time it's a clinical diagnosis. I usually tell my patients, asthma is a clinical diagnosis. We look at the history, we look at how the child behaves, and just the small parts we can confirm, okay? But most of the time, we confirm from the clinical presentation. So, but for other children, especially older children, we do some lung function tests, from like 6 years and above. We want to measure the lung volume capacity. We want to see if this child is able to expel all the air out.
So in other words, you want to measure how much air the child can take in and how much they can bring out.
Yeah. Then we look at what do we expect according to this child's age and height. What do we expect?
So you tell my child to breathe in, you measure how much they breathe in and how much they breathe out.
Yes.
And then you compare with what is expected for their age. And
exactly. Then we know if it is below that certain average, then we know for sure there is some limitation. Remember I talked about limitation of airflow and which comes because of narrowing. So then we know you cannot expel.
Maybe air is not entering nicely or
is not getting out well. So then we can know that for sure this is asthma.
So you said that starts at what age?
From 6 years and above. Because remember, these are also tests we do because the child is able to comprehend, is able to follow instructions. So if we tell them to breathe in, they should be able to inflate their lungs, you know. So below 6 years it's difficult, you know. So it's also about the age and ability to follow instructions.
Thank you very, very much.
And sometimes we also we do give them medication. If they come in an attack, we give them medication and we check the airway and see if it has opened up, then we know for sure that is asthma. So we can also use those simple
Can asthma be seen on X-ray?
Now that is something
because sometimes we get parents asking us, you're just saying asthma, can you do an X-ray and confirm it?
I know. And it's not only parents, by the way, even us health professionals are doing a disservice. So you find that they send these children who have difficulty in breathing, they're sending them for CT scans, X-rays. All these are radiations that you're exposing these children to unnecessarily. So you cannot confirm a diagnosis of asthma doing a chest X-ray. We do chest X-ray if you want to rule out complications, other things that are happening in the lungs, complications of pneumonia and maybe other abnormalities, but not asthma.
Okay. Says, dear viewers, you've heard it from the expert. Very often you are asking us to confirm the diagnosis of asthma in your children. And please, please, as long as your child is less than 6 years, it's very difficult to confirm the diagnosis. So we base on the clinical presentation, on the signs and symptoms your child is presenting with to say, this is most likely asthma. So the confirmation or the confirmatory tests usually come in after 6 years of age, when the child can easily understand or comprehend what we are instructing them to do, because it involves taking a deep breath, holding it and then blowing out, which is very difficult for a child who is less than 6 years of age. And the good thing actually, most of the time, by the time the child reaches their 6th year, the episodes have come down. They've even learned how to deal with the environment, so that attacks are very less. Yes. Now, this thing called asthma can happen in the night, on a trip, on a family day out, and so many places where we are very far away from the health worker. As a parent, how would I deal with my child who has an acute attack?
You know, if we talk about asthma, Dr. Helen, we need like 5 days.
Yeah, true.
Not just a few minutes, you know, because there's a lot to discuss, especially regarding management. First of all, in the management, when we want to treat asthma, we're looking at 2 aspects. We're looking at the medication. Remember to deal with the airway, which we talked about, the narrowed airway, We want to restore this airway, okay? Back to the normal airway. So there are drugs we use to relieve the obstruction, the narrowing that has happened here. So we use some drugs, we use inhalers, which are drugs that have been studied. They are safe and they are important to reverse this narrowing back to the airway so that air can enter freely. Then there are drugs we use to also manage the inflammation. Okay? So these inhalers, depending on what the trained doctor has said, if your asthma is intermittent, once in a while, most times we use one type of inhaler to only open when the attack has happened.
You see, asthma is very big.
Yes.
I'm very sure we may have to have you next week.
That would be great.
To talk about management of asthma in detail. But I'm looking at, I went with my child for swimming, and as my child was busy in the pool, they started having chest tightness and difficulty in breathing, what can I do as a parent at that
particular time? Of course, as you prepare to go to hospital, because I imagine you are not even aware, you don't even have inhalers, they have not told you, but your child, you suspect, but then a child is having actually difficulty in breathing. First of all, control the environment where you can. Make them warm.
Okay.
Dry them up if they're from a swimming pool. Give them something warm to drink. Make sure they are well clothed with warm clothing. And if you can, if you have any maybe antihistamine or drugs that help reduce mucus, like a cetirizine, you can give them as you prepare to go to hospital. Because I wouldn't encourage people giving steroids like prednisolone, Dexa, that they usually have in their home. Self-medication is bad, especially when it comes to asthma. So you do what you can to keep the child warm, because remember, cold air is what probably could have triggered, or excessive exercise. So as you really head to the hospital, if you do not have inhalers and no one has told you about asthma.
So if I have an inhaler, I can go ahead and use it. If you have an
inhaler, automatically, that is the first step to relieve the obstruction. You give an inhaler, you puff the child, depending on the age and what the doctor has recommended about the dose, you puff them, and as you relieve the obstruction, and then you see the next steps.
Thank you very, very much, Dr. Kutamba Elizabeth. Today on the Pediatric Voice, we have had a discussion, asthma in children, and clearly had an in-depth discussion of what asthma really is, what brings about asthma, what are the risk factors, the triggers to asthma, and we've seen it is one of the commonest causes of school absenteeism and emergency management in different hospitals. If you go to different emergency departments of so many, both in Africa and in the developed world, with so many hospitals, you'll find that the biggest number of emergencies they receive on a daily are because of an asthma attack. And this does not only occur in children, but in adults as well, and yet it is actually more common in more than 50% of asthma patients that come in the different facilities are actually children. And it can actually cause mortality and developmental delays amongst our children, school absenteeism, poor performance because of missing school, and sleep disturbances, among others. And because of that, we feel it would be very important that we get to understand asthma to the depth, and that is next week. We shall still have another episode on asthma in children, and we shall look in depth on the management of asthma. We shall look at how best can we prevent an attack in our children, how do we do the environmental control, how do we manage a child who has had an asthma attack at a point, and what about how do we maintain, restore this lung from the one that has chronic inflammation or that is partially narrowed to that normal lung? How best can we improve the livelihood of our child? Remember, sometimes these children are restricted from the daily activities like sports, like swimming, and so many, singing, and so many other things. But how can a child who has a gene for asthma live a comfortable life and enjoy life to the fullest as other children? And that's all we shall look at next week. That is it we had this week on the Pediatric Voice. Until we meet next time.